So let's start with this next module. This module is mainly going to be on eyes and ears, a bit on antidotes, a bit of bioterrorism, just a combination of things. So this image here is really just showing all the different services that are available. I mean, if you look at the bottom at around 7 o'clock, hospitals, mental health, behavioral health, long-term care facilities, emergency response, ambulatory care, such as clinics, all the different clinics that we have, public health for, something like COVID infections, reporting of infectious diseases. So that's very important. First responders, ambulance, fire, police. So it's just giving you just the circle of all the services that need to have some degree of communication between them. Okay, so this slide is showing you 3 images, and it's important to know the difference here. Okay, so the first slide is just showing you a side section of the eyeball. So we're looking at the top slide, and the first part that the light hits is the cornea, and then it goes into something called the anterior chamber, which has fluid in it called aqueous humor. Okay, so that's the anterior chamber. That's before your pupil, and your pupil is made up, of course, of your iris. That's what gives your eye your color. And then behind it is the lens. And then further behind, it's not shown here, is the retina, the back of the eye, right? So the fluid, the eye is filled with fluid. Okay, so the fluid is made in the ciliary process, and it is excreted. Look at the arrows. It has to go into the anterior chamber, so it has to go through the pupil. Okay, this is just showing you one little section of it, but it goes through the pupil, and then it drains out through this trabecular meshwork, these little tiny canals called the canals of Schlemm, which are kind of a cool name. And then the aqueous humor drains out there. Okay, so if you think about it, there's really only 2 ways to increase the pressure in the eye, because that's what we're going to be talking about soon. You either have a blocked trabecular meshwork, or you make more aqueous humor, which is very unusual. You wouldn't make more aqueous humor. Usually it's a problem with the drainage system. Okay, so if you have reduced drainage but continued production of fluid, then you're going to have a gradual increase in your intraocular pressure, your IOP. So let's look at the 2 conditions here of glaucoma, because glaucoma comes in 2 varieties really. There's open angle glaucoma, which is the vast majority of people you're going to see. okay, over 90%. This is the old age glaucoma. People into their, okay, I'm not going to say 60, but how about 70s, 80s? I mean, you can get it in your 50s or 60s, but typically it's 70s, 80s that you're going to get open angle glaucoma. So what does that mean? So open angle glaucoma is just telling you that the angle of where the cornea comes in to the corner there, where the trabecular meshwork is quite open. Okay, it's open, so there's nothing being blocked from the iris. Okay, and if you look there, that's just a normal anterior chamber angle, and that's just how that person was. That most of us are made that way, with a normal angle between the cornea and where it meets the iris. And then you have the fluid, the aqueous humor, that drains into the trabecular meshwork. So that's a normal anatomy. So what happens in open angle glaucoma is that trabecular meshwork gradually gets blocked up as you get older. Those little tiny canals just gradually get blocked up. They are not as efficient at draining the aqueous humor, and you gradually get increased intraocular pressure within your eye, and that's called glaucoma. Okay? So this type of glaucoma is by far the most common. And this type of glaucoma, it doesn't matter if you take a medication that dilates your eye. It doesn't matter if you're in a dark room and your eye gets dilated, because the iris, or the pupil, when it dilates and the iris bunches up in the corner there next to the trabecular meshwork, it's fine. There's no abnormal angle where the iris is now going to block the drainage, as we're going to speak about in a minute. So in open angle glaucoma, you can think of it as the chronic glaucoma that older people get, that they end up having to take drops to reduce their intraocular pressure for the rest of their life. And why do we give people drops for intraocular pressures of greater than 20? Because we know that if you have chronically elevated intraocular pressures, it damages the optic nerve. Okay? And when you get damage to your optic nerve, you lose your vision. So you often lose your vision, your visual fields. So that's why people with glaucoma will take drops, with open angle glaucoma will take drops for the rest of their life to either reduce the aqueous humor production or to help with the trabecular meshwork flow. So those are the two ways you can reduce intraocular pressure, right? Reduce the amount that's produced, or help increase the flow through the trabecular meshwork. Okay, so that's chronic open angle glaucoma. Closed angle glaucoma, very different. This is an emergency when it happens. And if you look at this, it's just the way the person's eye is made. The cornea, when it comes into the corner there, it comes in at a more narrow angle. So when the pupil dilates, it gets bunched up in that corner and closes the flow, shuts off the flow potentially in a narrow angle glaucoma. Okay? Or what we call a closed angle glaucoma. So basically the cornea is more narrow, the angle is more narrow. So anything that causes the eye to dilate and bunches up the iris into the corner, into the corners between the cornea and the iris, can completely block off flow into the trabecular meshwork. And when that happens, you get a sudden increase in intraocular pressure, severe eye pain, right away, typically associated with a severe headache and vomiting. Okay, so this is an emergency. This has to be fixed today. This is an eye-threatening, a visual loss emergency. So it needs to be dealt with today. So understand that anything, and there's many drugs that you may have heard of that have anticholinergic effects that dilate the pupil. A dark room can dilate the pupil, but there's many drugs that we use that can dilate the pupil. So you'll often hear that to avoid this drug in patients with glaucoma. And that's true, but really what we're saying is avoid this drug if you have a history of closed angle glaucoma, because you could set off another event of closed angle glaucoma emergency. Okay? So really it's an acute blockage of the trabecular meshwork from a dilated, bunched up iris that's blocking flow. Okay, so there's two different glaucomas. Make sure you understand the difference. One, non-emergency, chronic, needs drops. That's called open-angle glaucoma. Just need to control the pressures in the eye. The other one, an acute increase in intraocular pressure. The canals of Schlemm have been completely blocked off from the dilated iris or pupil, and medical treatments and surgical treatments need to be done today to try and save that eye. Okay, so in this slide, let's look at the anatomy of the eye. And things always make more sense when you have a bit of anatomy, a bit of pathophysiology, a bit of physiology, and then you understand the drugs more, right? So let's just pretend that we're a light beam coming into the eye. We spoke a bit about this on the previous slide. And the first thing that the light beam hits is the cornea. And then after the cornea, it goes into the anterior chamber, which is filled with fluid, right, called aqueous humor. Then it goes through the pupil, right, and the pupil is made up of the pupil is a hole that's made up of the surrounding iris, right, which gives your eye your color. And then the light beam goes through the lens, and then into the main part of the eye called the vitreous body, and the fluid in the back we call vitreous humor. Okay, and then the light beam continues on and hits the retina, and it typically hits your central vision, which is at the macula. And right in the center of the macula is the fovea, where there's many, many receptors to have a really sharp central vision. Okay. Now, of course, there's the rest of your retina that's also able to pick up your peripheral vision, moving objects that are in your peripheral vision that you can still see, but not as clearly. And then of course there's the optic nerve that's going to take all of these, all of the information from the retina and turn it into a nerve to then go to the brain. Okay, and then it can be interpreted in your optic cortex, which is at the back of your brain. So your optic nerve and your optic disc is actually your blind spot. It's the one defect in the retina where there's no rods or cones. There's nothing there to pick up vision. So that's what gives you your blind spot, because the optic disc is where the optic nerve is leaving the eyeball. Okay. So when we're talking about glaucoma, it's all about the production of aqueous humor in the ciliary body that then has to find its way and flow its way through the pupil into the anterior chamber and then drain out through the trabecular meshwork and the canals of Schlemm. So it's a production of fluid versus the excretion of fluid. And if that is somehow affected, then the pressure in your eye will usually increase. And the vast majority of the time is that it's not an issue with production of fluid. It's an issue with, well, either you're just getting older and older, and all those little tubules and meshwork that was draining the eye before are gradually just getting blocked with old age, and you have chronic open-angle glaucoma. Versus someone who just was made with a narrow angle cornea where it meets the iris, and when the pupil dilates, whether it's from darkness, whether it's from drugs, it bunches up in the corner. The iris bunches up in the corner and causes an acute closed angle glaucoma, which is an emergency. Okay, I hope that makes sense. Okay, so now we're just going to talk about different types of drops that can be used for controlling glaucoma. So most of these drops will be for the chronic glaucoma, because that's by far the most common. The majority of drops made on the market are for open angle chronic glaucoma. But we do have drops for closed angle glaucoma. Even though it's much less common, it's still important because we have to do something for this eye-threatening condition. So timolol is a beta blocker, and through having studied this over many years, we realized that this reduces the production of aqueous humor at the ciliary body. Okay, well, that would be perfect for open angle glaucoma. You can reduce the production, and that will reduce the intraocular pressure if these eye drops are used every day. Okay, so this is an old glaucoma treatment that's still effective to reduce the intraocular pressure. It does come with some side effects. Most drops can cause burning or stinging, but most drops don't cause, potentially, bradycardia, congestive heart failure, or depression. So these drops, just like any beta blocker, they can cause beta blocker systemic side effects if they get into the systemic circulation, which is far less common than taking a pill, of course, but they can still get into the systemic circulation and have an effect like a beta blocker. And so a beta blocker can cause bradycardia. A beta blocker is a negative inotrope, so it could aggravate congestive heart failure. And beta blockers, one of their side effects is fatigue, depressive symptoms, very common in beta blockers. Okay, so those side effects are if it gets into your systemic circulation. So what about the contraindications? Well, beta blockers, remember, they can block the heart. Those are beta 1 receptors, but also they can have an effect at the beta 2 receptors by blocking them. So we want to avoid that in someone with asthma, COPD, anyone who has already bradycardia, some kind of a heart block where their heart is already beating slowly. We wouldn't want to slow it down further with a beta blocker such as timolol. Again, heart failure, probably try to avoid timolol since there's many other options. And being a bit careful in diabetics, because remember, it's not that it makes necessarily a mess of diabetes and your blood sugar. It's just that if you have a beta blocker that's circulating in your bloodstream, if your sugar were to suddenly drop quickly, the sympathetic system can't warn you because you have a beta blocker circulating in your bloodstream. So it can't give you the warning of hypoglycemia, such as an increased heart rate, sweating, pale. Those can be symptoms of hypoglycemia. So a bit careful. We're always careful with beta blockers in diabetics. Okay, so 2 to 4 weeks of treatment to reach therapeutic effect. Sure, it takes time to reduce the production of aqueous humor in the ciliary body. These people will have follow-ups to check their intraocular pressures of their eyes. It's typically both eyes, by the way, that's affected by glaucoma. Not always, but typically both. So these are lifelong drops to keep the pressure, the intraocular pressure low in the eye and prevent damage to the retina and the optic nerve. Okay, so let's talk about the next drop, latanoprost. Okay, so this drop reduces intraocular pressure by increasing the outflow of the aqueous humor, so the drainage of the aqueous humor. Well, that's not going to be very helpful in closed angle glaucoma, right? The iris is all bunched up at the canal of Schlemm. There's no flow, so there's no sense in trying to open those little canals when the iris is blocking the whole area. So this is for chronic open angle glaucoma. There is an interesting side effect to these drops. They can cause some staining and some pigmentation of your eyelashes and your eyelid skin, and also actually your iris. So you will be told this if you were to start these drops, that can cause some staining of eyelashes, eyelid skin, and even the iris as well. Okay. Contraindications, I won't go into those too much. Closed angle glaucoma is a contraindication, but really it's also it just wouldn't be effective either because of what's happening in closed angle glaucoma. And again, this would be for chronic open angle glaucoma. They will take these drops, assuming they're effective, by follow-up visits and checking their intraocular pressure. But they will take these for the rest of their life, unless there's a significant side effect. Okay, so brimonidine. So notice that this has the ending of clonidine. So already, if you know a bit about clonidine, or if you've heard of clonidine, you'll know that this is if this gets into the systemic circulation, it's going to have similar side effects to clonidine. So let's go through it. And again, so this one decreases a bit the aqueous humor production and also helps increase with the outflow of the aqueous humor through the canal of Schlemm. Okay, used for open angle glaucoma only. Okay, because these drops just don't work that fast, right? There's going to be a drop that we will talk about that we use for closed angle glaucoma. And by the way, I did mention, we did talk about timolol a couple of slides ago. And we spoke about the fact that it reduces aqueous humor production. That's not going to be that helpful in acute closed angle glaucoma. It's too much of an emergency. So we will talk about a drop that we do use for closed angle glaucoma because we need to get that pressure down immediately. It's usually extremely high. Okay. So these drops, again, open angle glaucoma, chronic condition. Just going to repeat myself so you get it. Adverse effects, okay, stinging discomfort, any drop can do that. Blurry vision, any drop can do that. Dilated pupil, okay, well remember it's similar to clonidine, and clonidine is a alpha-2 agonist. So it can have some sympathetic effects. It can dilate the pupil a bit. It's a sympathetic agonist of the alpha-2 type, right? Alpha-2 agonist. But look at the other, if it gets into your bloodstream, it has very similar effects to clonidine. A headache, hypotension, drowsiness. That's all clonidine coming back. And it's because clonidine, the alpha-2 receptors, are in the brain, and they reduce blood pressure when stimulated by something like clonidine or brimonidine, and you get hypotension. And because it's in the brain, you have CNS side effects like drowsiness. Okay. Responsibilities: removing contact lenses prior to administration and leaving out for 15 minutes. That would be for pretty well any drop that you take, whether it's an antibiotic drop or a glaucoma drop. You need to remove your contact lenses. Okay, so let's look at pilocarpine. So pilocarpine is a cholinergic agonist. So it's going to cause the pupil to constrict. Okay. So why would we want the pupil to constrict? Well, we use this drug in acute closed-angle glaucoma. So this is the drop that I was talking about that you can use, and we can put drop after drop after drop to get the pupil to really constrict. And what that does is it pulls the iris away from the bunched up corner that it was in acute angle acute closed angle glaucoma. So with that effect, you're allowing the drainage to open back up because the iris is being pulled away. Okay, so pilocarpine is used for closed angle glaucoma, which is the emergency one. So it lowers the intraocular pressure by pupillary constriction and spreading back out that iris that was bunched up. Okay. Adverse effects. So if it gets into your bloodstream, it could definitely have parasympathetic effects. So that would be bradycardia, maybe some hypotension. That's only if it gets into the bloodstream. Decreased visual acuity. Well, you're making the pupil pinpoint, so less light is going to get in. So you will have decreased visual acuity. Retinal detachment would be rare, but remember that the iris is actually continues beyond what you can see, and it goes around to the back of the eye. It's part of what's called the choroid. The choroid, choroid. So because of that, when we're constricting it and we're pulling the iris and stretching it out and constricting the pupil, you can cause a retinal detachment. It would be very unusual though. So again, just know that this is to reduce the pressure in closed angle glaucoma, and it's used with some other medications that we're going to talk about. This is not something you would use in open chronic glaucoma. Can you imagine walking around with a very small pupil day in, day out, reduced light getting in? That's not something that we would want to do. Okay, so dorzolamide. So this is the eye drop form. It's in the same group as acetazolamide, but they're used for different things. Okay, so acetazolamide we'll talk in a minute. That's an intravenous drug. Dorzolamide or brinzolamide, those are just drops, and they're used for chronic open-angle glaucoma. That's it. Just dried eye drops you're going to put in every day to control the intraocular pressure. Acetazolamide, which is an intravenous drug, it's in the same group as this eye drop that we're talking about called dorzolamide, but this is the IV form, So IV acetazolamide, that's an extremely powerful diuretic. It's a carbonic anhydrase inhibitor. So if you go back to the renal section, you'll see it there. And that drains a lot of fluid and what we're in the kidneys. And what we're trying to do is pull some fluid out of this eye that has incredibly high pressures in it. So IV acetazolamide is for closed angle glaucoma. And then they came up with a drop called dorzolamide, and that's just to reduce the pressure of open angle glaucoma, okay? Because it decreases aqueous humor production. So don't confuse the two, even though they're in the same group. One's an IV drug for emergency glaucoma, and one's just for open angle glaucoma. I won't get into anything else about it, as long as you know the difference there, and that IV acetazolamide is really for, we need to get the intraocular pressure of this closed angle glaucoma down immediately. Okay? Okay, and mannitol. So mannitol is really just a large sugar molecule. But IV mannitol, we're trying to do the same thing. This is an emergency, closed angle glaucoma, and mannitol pulls fluid either out of the brain tissue, or it can pull some fluid out of an eye that's under very high pressure. So we can use it for closed angle glaucoma. So it's an osmotic diuretic, and it can help by reducing the intraocular pressure in this emergency of closed angle glaucoma. This is not for open angle glaucoma at all. Now, because it's such a powerful diuretic, you can drain tremendous amounts of electrolytes. You can drain tremendous amounts of fluid, so you can get hypovolemia. Initially, when you inject it, you're actually pulling a lot of fluid either out of the brain or out of other tissues that are under pressure. So you can get volume overloaded, so we try to avoid it in heart failure or pulmonary edema, prior to it having its diuretic effect where it drains the electrolytes and drains the fluid at the kidney. Okay. Contraindications, so there you go. Well, anuretus means you're not making urine. So if you're not making urine, your kidneys probably aren't being perfused or they're not functioning. So we wouldn't use a diuretic if they're not working. Heart failure, well, because you're drawing so much fluid into the intravascular space and then taking it to the kidneys to be drained, that's its overall effect. We would avoid it in heart failure. We would avoid it in severe dehydration or shock because it can potentially really drop your blood pressure as it's having its powerful diuretic effect, right? And draining you of fluids and electrolytes. So this is an IV drug for emergencies like cerebral edema or closed angle glaucoma. Okay, so let's move on to some ear disorders. We'll talk a bit about outer ear infections, middle ear infections, and some of the treatments that we use for them. Okay, so this is a diagram of the ear anatomy. You can see that the outer ear, which is the helix, is well, first of all, it's all made up of cartilage, and that little cartilage piece at the front called the tragus, that'll be important when we're talking about putting in drops. We'll come to that in a minute. So the helix is the whole circular part of the ear, the top as it encircles, and that would be called the external ear. And then the canal inside is called the external auditory canal until it gets to the tympanic membrane. And then it becomes the middle ear. And the middle ear has the bone, the three little tiny ossicles in them, the little tiny ear bones. It also has the eustachian tube that goes to your throat, which allows the middle ear to be aerated. And then that goes to the inner ear, which is involved in balance, which is the vestibular system. And the cochlea is, of course, involved in hearing. And they combine together to form the 8th cranial nerve that goes to the brain. Okay? So this video is going to show you installation, putting in eardrops properly, and how you use the tragus to get the eardrops to the back of the outer ear. Remember, drops don't typically go beyond the eardrum, right? The tympanic membrane. Unless, of course, there's a hole in the tympanic membrane, like there's a rupture, and then they'll go into the middle ear. But normally, if you just have an outer canal infection, so an external canal infection, called an otitis externa, with no perforation of the eardrum, the drops will only go as far as the tympanic membrane. And then a middle ear infection, which most of the time you would think of as the one requiring oral antibiotics, and that's called an otitis media. Okay, so outer ear infections require drops, otitis externa. Middle ear infections, called otitis media, require oral antibiotics to be treated. And these are just some of the symptoms that you'll come across in terms of what can happen when a part of the ear is affected. So, I mean, we can go around it a bit. We'll start at the top. Ear scratching is going to be some kind of a rash or irritation. You can get eczema within the ear, which will make it itchy. Brown, yellow, or bloody discharge, that's usually an otitis externa, or it could be an otitis media that's ruptured the tympanic membrane and is now leaking out of the external canal. Odor in the ear, again, is often otitis externa, but it could be, again, a ruptured eardrum and the fluid or the pus is leaking from the middle ear. Redness of the tympanic membrane typically indicates an otitis externa. Redness of the external canal would indicate an otitis externa. Walking in circles, that's usually a labyrinth problem, so the vestibular system. On the previous diagram, the vestibular system is responsible for balance. So if you have a disturbance in the vestibular system, such as labyrinthitis or Meniere's disease, you can be very off balance. I don't know if you'd walk in circles, but you'd be off balance. Hearing loss can be a whole constellation of things. It can be right from the outer ear, such as earwax, a middle ear infection, so otitis media, a problem with the cochlea, or a problem with the 8th nerve can all cause hearing loss. Unusual eye movements, that refers to something called nystagmus, and that's typically from the vestibular system. Loss of balance, vestibular system. Head shaking or head tilt, that would be a vestibular problem as well, because that's really involved in the balance and how you are able to, the vestibular system gives signals to the brain to tell the brain where you are in terms of like where you are in space and how are you standing and your gait, your movements. Wiping the ear area on the floor or furniture. I'm not sure about that. Hair loss around the ear. I don't know about that either. I don't know. Crusted or scabby skin on the near ear flap. Well, I mean, again, that could be an eczematous rash of the skin. That could be discharge that's now crusted on the skin on the outer ear. Swelling of the outer ear, like the helix or the canal, is often associated with an outer ear infection. So just an idea. So the hair loss, can't explain that. Wiping the ear area on the floor or furniture, that sounds like something a pet would do. I don't think we would typically do that. Okay, there you go. So just remember, there's different parts of the ear, right? Outer ear, middle ear, the cochlea, and the vestibular system, plus the eustachian tube. Okay, so for otitis media, which is an infection behind the eardrum, in the middle ear, where those bones are, is typically in children, and it's often because the eustachian tube has become blocked because they have a cold. So otitis media is usually secondary to like a viral infection or a sore throat where the eustachian tube is blocked in a child. They get backup of fluid into the middle ear and they develop an otitis media. Can't get these infections with drops because the drops don't go beyond the tympanic membrane. So we use oral antibiotics if we want to treat them. Typically under the age of 2, we always treat otitis media. As children get older, there can be a more watch and wait approach, and then if it persists for 2 to 3 days with pain that's not settling, we often give them ibuprofen for the discomfort because a lot of them settle by themselves. But if they don't, we can use a medication such as amoxicillin or amoxicillin clavulanic acid, which is called Augmentin. So the idea is to try and clear the bacterial infection in the middle ear, right? So amoxicillin is given 3 times a day, usually with meals. Often advised always to finish any particular antibiotic that you've started. And I think that's about it for amoxicillin. There's many antibiotics we use for middle ear, so don't think this is the only one. There's many antibiotics. This is one example of an antibiotic to treat otitis media. Okay, so ciprofloxacin / dexamethasone ear drops. So this is to treat an otitis externa. So if you go back to that diagram, you'll see that these drops can easily get to the outer ear canal, okay, and treat an infection of the canal that goes to the eardrum. And often we call this swimmer's ear. It's very common in the summertime where people are swimming in lakes and they get an outer ear infection that requires drops. There's an antibiotic in it called ciprofloxacin. There's also an anti-inflammatory, because a steroid anti-inflammatory, dexamethasone, because the canal is often inflamed and swollen, so it really settles down the inflammation and the edema. Okay. Very few side effects. Remember, you always want ear drops or anything that you're putting in the ear, any liquid, you want it to be the same temperature as the body. If it's very warm or very cold, you're going to stimulate the vestibular system and it'll produce dizziness, vertigo. The person's going to start to spin. So if you're ever wondering what cold water does in your ear, it'll stimulate the vestibular system and you will just spin and spin and spin because that side of the brain, that vestibular system is being stimulated. So pretty careful that, we tell people don't use these drops if they're cold. It's going to make you feel dizzy. Okay. Okay, so we finished briefly with the ears and the eyes. I'm just going to talk about emergency preparedness, a bit of bioterrorism, management of poisonings in this next part. So remember, the word triage means that, so it's a French term, and it means deciding on which patients should be seen first. So, for example, if someone comes in with severe abdominal pain and they're hypotensive compared to someone who comes in with a cold, we're going to see the abdominal pain with unstable vital signs first, right? They're gonna rate much higher on the triage list, and the triage list or the triage numbers is usually 1 to 5. 1 being critical, and 5 being very low acuity, can wait a very long time. So, and usually there's a list in emergency rooms of what makes a triage 1, what makes a triage 2. Of course, nurses that have been working for a long time just know it without having to look at the list. But that's what the idea of triage is. You know, if you have 10 people coming in, who's being seen first? Who's being seen second? Okay. This next slide is really just to show you in a general sense emergency management and disaster preparedness for, say, a city or an area, right? So in the top right corner, there would be the planning and preparedness. So that's usually, you know, communications between the governments, the different levels of governments, the operations of different parts of the system, emergency response plans, the training and exercise of all those different groups. The response, well, when something happens, such as a pandemic or some major event in the city, then there's the response phase. Then there's the recovery phase. So if it was an earthquake, debris management, economic recovery, disaster housing, and then followed by mitigation, right? And the mitigation is really to avoid even more deaths and more injury. So public education, improved infrastructure, an assessment of the disaster, looking at vulnerabilities in the city, say during an earthquake. So it's just a general slide. I don't think you need to read too much into this slide. Just some information. Okay, so emergency severity index. So this is the triage system I was talking about earlier. It's a level. It's triage from 1 to 5. 1 being critical, unstable patient, all the way to a 5, which is someone maybe that just needs sutures removed, or someone who stubbed their toe, something like that. In a 1 or a 2, we're usually going to hear the story from the ambulance, because they're usually coming in by ambulance, and we'll usually prepare. We'll get prepared for triage 1s or 2s, because usually we're going to need some equipment ready. They might need intubating. They might need cardioverting. They're going to need a monitor, IVs, oxygen. So we usually get prepared. We have a bit of time to get prepared for the higher acuity patients. So it gives a reliable, it gives an idea. Like, for example, if the nurse comes and says to me, we have a triage 1 coming in, that usually says, okay, let's get ready for this. There's something critical coming in. Okay. So it really helps discriminate between many people that are waiting at the same time. Now, if you have a disaster, say an explosion, and you have 20 or 30 people coming in, the sickest may not be the first person to be seen. because you have to remember it also depends on the resources of the hospital, the staffing of the hospital. So if you have an 85-year-old that has a 90% burn, well, he or she is very likely going to die. We're not going to use all our resources and time trying to save an 85-year-old with a 90% burn. So he or she would actually drop down the triage list because likely not savable, not survivable. So triage, now that doesn't often happen that you have 20 people coming in, but when it does, when there's an explosion, the triage changes a bit because you have to also decide, well, who is survivable, right? Whereas usually emergencies come in one or two at a time, and we can triage them, but usually we're still going to be able to use all our resources trying to save them. Okay, so getting the right patient to the right resources in the right place and the right time. So it's not always the sickest person if there's many people that are trying to use the same resource. It's the one that is most likely also to survive with a good outcome, because we could throw incredible amounts of resources at a critically sick person whose chance of survival is close to zero, while other patients are dying that could have been survivable. So it changes when there's a larger scale emergency with many patients coming in. So this next slide is just showing you some basic questions. Is this patient dying? Is this a patient who shouldn't wait? How many resources are needed? What are the vital signs? So if this is the only person and everyone else in the waiting room isn't that sick, well, this person's going to rate very high. Is this patient dying? And if the answer is yes, okay, they're going to come back. They're going to be a high priority. What are the vital signs? If they have unstable vital signs, they're coming back. Okay, then we're not going to put them in the waiting room. So they're going to rate a much higher triage number. So it really helps because if you have 10 people in the waiting room, you can kind of look through the charts to see, oh, we have a triage 3 here amongst all these triage 4s. And let's take that one out first and have a look at that patient. Okay, and another slide on hospital triage. So deciding not sick, too sick, and sick. Okay, so not sick, they can wait. Too sick, meaning amongst all these people that need to be seen, and many of them are critical, you're so sick that you're not survivable. And again, I'm referring to a mass casualty event like an earthquake or an explosion. Obviously, if someone comes in and they're critically ill and they're coming in typically as they do in a North American hospital and they're extremely sick, they come back first, right? I'm talking about 30 or 40 people and trying to decide, okay, you're very sick, are you survivable? And if you are, okay, let's take care of you first, versus you're very sick and you're so sick you're not survivable. Okay. So in trauma, we always get the vitals first, right? Get the vital signs: heart rate, blood pressure, O2 saturation, and in a neurological status. Are they looking at you? Can they talk to you? Are they unconscious? So it always goes airway. So airway, is their airway open? Are they able to bring air into their lungs? Or are they choking? Do they have stridor? Do they have an upper airway obstruction? Do they have something in their mouth that's causing them not to be able to get air in? Do they have neck swelling? Do they have facial swelling? Is their mouth full of teeth? So airway is first. If you look at the airway and you're happy with it, breathing. Okay, How are they breathing? And look at them first. Are they breathing fast? Are they in respiratory distress? Is their respiratory rate 40 or 50? Is one side of their chest rising and the other one's not rising? Do they have a sucking chest wound? Do they have a flailed chest? Do they have a pneumothorax? So we'd look and we listen, okay? And if we're happy with the breathing, we move on to the next one. And this can happen very quickly. It doesn't have to be 5 minutes for each one. And often these are done in sequence if you have enough, or together if you have enough staff. Circulation. Are they tachycardic? Are they hypotensive? Do they have a good capillary refill? Do they look pale? So all these circulatory questions. Disability really stands for neurological status, okay? Their Glasgow Coma Scale. So the Glasgow Coma Scale is a scale from 3, meaning you're basically unconscious and there's no activity at all the way to 15. Okay, so and it gives us a really accurate assessment of their neurological status. Are they awake? Are they looking at me? Can they speak to me? Can they say good morning? Or are they obtunded, confused? They don't know where they are because of a head injury. Or are they just unresponsive with no movements of their arms or legs? So neurological status is very important, especially once we're going to start giving them drugs that's going to make them unconscious. We need to know their neurological status prior to that. And then exposure is taking off all of their clothes to see any other potential injuries, right? So they may have a hidden injury to their legs, to their arms, to a chest or abdomen or back. So we remove all the clothes to have a look to make sure that we're not missing anything. Okay, so just some general treatment strategies and poisonings. So whether the poisoning is something that's been ingested, like an overdose, or whether it's a poisoning on the skin or the clothing, these are just general ideas in poisoning. So always to protect the staff and yourself, right? So if someone comes in and they're soaked in some kind of a chemical, you're going to protect yourself with proper with a mask, with a gown, with a face shield, with gloves, right before you approach the patient. That includes any staff member. And then, of course, if someone is soaked in some chemical, you're going to decontaminate them, right? So that's removing the clothing. Often it involves washing them down. A lot of poisons or toxins can be absorbed through the skin, so topical decontamination. Prevention of absorption, what we just mentioned in terms of the skin, with removal of the clothing, decontaminating the skin with water. GI, gastrointestinal decontamination, or to prevent absorption, is often with charcoal. Many drugs bind with charcoal and never end up getting absorbed, as long as it hasn't been for many hours. If it's in the first 2 to 3 hours, we'll use charcoal. If it's been 12 hours, it's too late. The poison has gone through the stomach and traveled on, right? And likely been absorbed. Neutralization typically means neutralizing the toxin that's already made it into the bloodstream. So, for example, chelating agents are agents that bind to heavy metals. So if someone has a heavy metal poisoning, we'll get into it later, we can use chelating agents that can bind to it. Another example would be if someone has a poisoning with digoxin. You could use Digibind, right, to neutralize it. We have neutralizing medications for toxins. So it's already made it past the gastrointestinal tract. Now we have to address the fact that it's in the bloodstream. Okay. Then there's, well, it's in the bloodstream. Let's see if we can increase the excretion rate. So often that involves increasing IV fluids. Some poisonings are excreted much better in a higher pH surroundings or serum pH. So sometimes we'll give bicarbonate to make the serum and the urine more basic so that the drug or the poisoning can be excreted. Some poisonings are excreted better in a lower pH, a more acidic environment. So we can give a medication to lower the pH, but usually it's to raise the pH with bicarbonate, which will help increase the excretion. And then there's specific antidotes for certain drugs, and we'll come to some of those. And often there's symptomatic therapy. So for example, if someone has severe nausea and vomiting, well, we can treat that with ondansetron, anti-nauseants to control the vomiting. So any poisoning can be treated symptomatically. If someone overdoses on, say, a benzodiazepine, so they're going to come in tired, they might come in breathing slowly. Well, we can treat that symptomatically with oxygen, maybe with some stimulation of them. If they're semi-comatose, we can do a sternal rub to wake them up a bit. We can give them IV fluids, but as well, there's an antidote, right? We can use flumazenil as the antidote for an acute benzodiazepine overdose. So it's often a combination of some of these treatments. So this is a bit of a continuation of managing poisonings. So initiating contact precautions for sure, for you to protect yourself. The Poison Control Center is always open 24 hours a day, seven days a week. So often we'll derive information from them for certain poisonings. Providing good ventilation and good oxygenation. If there was some kind of an inhaled toxin or a vapor, contaminated clothes are removed, skin is flushed, just to dilute the poison and stop it from being absorbed through the skin. If there's some kind of a irritant or toxin that's gotten into the eyes, they get eye flushing to really rinse out the eyes, especially if it's some kind of a chemical that's acidic or basic. We really rinse out the eyes. We rarely induce vomiting anymore. We used to use syrup of ipecac. We don't use it anymore. Often vomiting makes the poison come back and potentially irritate the esophagus again as it comes up. So we really don't use syrup of ipecac anymore. We'll use charcoal to try and bind poisonings or toxins. We may do what's called a gastric lavage, where we'll put an NG tube down and flush out their gastrointestinal tract with fluids. But syrup of ipecac is not used anymore. Do not give milk or water unless directed to do so. So we often don't give anything until we know what the poisonings are, right? I mean, if someone says that, like, I took some water at home, that's very unlikely to cause any harm. But we often don't give them anything until we find out what exactly is the poison or the toxin that you've taken. Okay, so let's just talk about a couple of bioterrorism agents. So the first one here is anthrax, which is a bacteria. And I mean, by far the most common way to get anthrax is someone who's working with animals, livestock, because they can carry livestock. Sorry, they can carry anthrax. I mean, military personnel would be at risk for anthrax because it's used as a bioterrorism agent, right? And this particular bacteria can get onto your skin and form these deep ulcers of the skin, or it can be inhaled and form lung infections. So with shortness of breath. So those are the two forms of anthrax. And these are treated with an antibiotic called ciprofloxacin. And there is also a vaccination available for anthrax. It's usually recommended for people who are at high risk of acquiring the infection. So the next one is botulism. So botulism you may have heard about in the past, especially maybe you've heard it in terms of under the age of 1, we don't give children honey because honey can carry small amounts of botulism. But in this case, it's being used as a bioterrorist agent. Clostridium botulinum is the bacteria that produces the toxin. And it basically causes a paralysis of the body. And there is a treatment for it, and it's an antitoxin. So it's an intravenous antitoxin. And typically, because it causes such profound weakness, you need to be on a ventilator, because you're unable to breathe with this toxin that's affecting your muscles and the nerves supplying the muscles. So antitoxin to try and clear the toxin, and a ventilator. Bubonic plague. I don't think you need to know too much about that. This is a bacterial infection that can be turned into a bioterrorism agent. Again, can be treated with antibiotics. Nerve gas agents, they're typically cholinergic in nature. So if there's a nerve gas poisoning as a bioterrorism agent, it causes intense cholinergic activity. So frothing at the mouth, nausea, vomiting, diarrhea, severe bradycardia, hypotension, all the cholinergic symptoms. And this can be treated with atropine. And that's partly why the military carry atropine as an antidote for a cholinergic gas poisoning. And then smallpox. I mean, smallpox is basically eliminated, except for, I think, 2 countries store small reserves of smallpox to use as bioterrorism in the future, maybe. But otherwise, it's eliminated. Was treated with it. It was. There is a vaccine for it. It's not given anymore because it's essentially not necessary. There's no smallpox in the general population. So signs and symptoms of ingested poisoning. So this is pretty straightforward. If you put a poison into your stomach or an overdose of a drug, typically the stomach will respond by saying, this is toxic to me, I'm going to try and get rid of it. So the first thing it'll do is vomiting, right? Abdominal pain, possibly cramping, vomiting, and then it'll flush it out, try and flush it out the other end with diarrhea. Now, this is very general. It depends on the poison or toxin that you're talking about, right? So this would be the equivalent of, say, you went to a party. We're not talking about poisonings right now, but say you went to the party and there's 20 people there and 18 of you went home vomiting with abdominal pain. Well, you likely had food poisoning, right? There was likely something in the sandwiches or the mayonnaise or the ham or the chicken that caused the stomach to cause intense cramping and vomiting to try and get the poison or the toxin out. Sleepiness or loss of consciousness, those are more along the lines of an opioid or a benzodiazepine, some kind of sedative is on board. Seeing bottles or containers of poisons close by, definitely a hint that something has potentially happened here. So we often look for indicators of a potential poisoning. You know, for example, if someone has taken some kind of a stimulant drug, cocaine, say they've overdosed on an oral decongestant. Well, what are they going to have? So they're going to have certain syndromes that we're going to be able to detect, or symptoms. So tachycardia, sweating, hypertension, dilated eyes. So that would be a sympathomimetic toxidrome. So you become toxic on a sympathomimetic drug. What about an anticholinergic drug? Say you took much too much, some kind of atropine type drug. You will get confused. You will still have dilated eyes. You'll be dry mouth, dry skin. Your gastrointestinal tract will shut down. You'll be tachycardic. So there's some similarities between an anticholinergic toxidrome and a sympathomimetic toxidrome. That's what we call them, but there's differences too between them. Okay, so here's some common, whether it's unintentional or intentional poisonings. So acetaminophen, well, some people may just take too much for too long, right? So the maximum acetaminophen in 24 hours is 4 grams. Well, some people think more of a drug is better. So maybe for the past week they've been taking acetaminophen every 2 hours and they've become acetaminophen toxic. Or an acetaminophen acute overdose. Sometimes younger people in particular will overdose on acetaminophen thinking that it's a relatively harmless drug, not knowing that it's a highly toxic drug in large doses to the liver. Opioids, well, whether it's street opioids or prescribed opioids, very common drug to be abused and used for a suicidal attempt. Right, so opioids. Well, if you take an opioid, what are the common effects? Pinpoint pupils, fatigue, all the way to loss of consciousness, reduced respiratory drive, so bradypnea, slow breathing, hypotension, and finally just going into a coma. Okay. So signs and symptoms of overdose, it just depends on the drug, right? So confusion could be with a benzodiazepine or an opioid. Elevated heart rate could be with some kind of a stimulant drug, such as cocaine, or it could be with an anticholinergic drug that you've overdosed on. That's now causing the tachycardia. Drowsiness. Drowsiness, again, sedatives, opioids can cause drowsiness, and benzodiazepines. Enlarged or dilated pupils, typically stimulants dilate your pupils. Anticholinergic drugs can dilate your pupils. Hallucinations, that could be from any kind of an anticholinergic drug or maybe some kind of a mushroom poisoning that you're now experiencing hallucinations. So how do we treat? Sometimes we don't even know what someone's taking, and we just have to treat them. And often we'll give them activated charcoal, right? So if someone comes in and they say, well, I just took, 50 Tylenols. Okay, well, you've taken it within the past couple hours. Let's give you charcoal and let's get the antidote ready, right? The acetylcysteine. Some drugs can be dialyzed off. So hemodialysis is usually what we would do if we couldn't stop the drug by being absorbed with charcoal or with gastric lavage, or if we thought it's at such a toxic level that it's going to cause serious harm to the person. Sometimes we'll consider hemodialysis. I would say a lot of poisonings, it's supportive treatment. It's supporting in terms of maintaining their blood pressure, monitoring their vital signs, maybe giving some charcoal, uh, giving them IV fluids. But there's some overdoses that have specific antidotes that we can talk about. Okay, so acetaminophen. So acetaminophen is a very safe drug unless taken in toxic amounts, and that's typically more than 4 grams in 24 hours. And it doesn't take a lot of acetaminophen to harm the liver. Okay, so we actually use what's called a nomogram, which is a chart, and we can measure with this chart. Okay, how much did this patient take? Let's check the serum level of acetaminophen, and is it at a toxic level at 4 hours post ingestion? And then we'll decide. Okay, let's give IV acetylcysteine. Now, if someone comes in and has ingested 50 tablets of 500 milligrams of acetaminophen, we can still do the nomogram in 4 hours, but we're going to start the acetylcysteine right away, right? So it's more the person that comes in and we just don't know how much they've taken. And even then, sometimes we'll start the acetylcysteine and get a 4-hour post-ingestion acetaminophen level to see if they're toxic. And if they're not at a toxic level, then we can stop the acetylcysteine. If they are, we'll continue it. Okay. Anticholinergic drugs. So if you overdose on an anticholinergic drug, so say you were just given much too much atropine or scopolamine patch behind your ear, you're just given too much. Well, we can help reverse that by giving physostigmine, which, remember, is a drug that blocks acetylcholinesterase. So it's going to allow more acetylcholine in the synapse and displace some of the atropine so that the synapse can start to work again, right? So physostigmine is going to raise the acetylcholine level in the synapse. Benzodiazepines have a definite antidote for acute poisonings called flumazenil. Now, if someone's been taking benzodiazepines for years and they just come in a bit sedated, drowsy, maybe breathing a bit slow, they need a bit of oxygen to maintain their oxygen saturation, we're not going to reverse them with flumazenil. It's going to fully reverse them. And when you fully reverse someone who's been taking a benzodiazepine for years, you're suddenly going to reverse all of those where the benzodiazepine's been attaching to the receptors, and you can put these people into acute agitation and acute seizures. Very difficult to treat seizures. So flumazenil is more for an acute benzodiazepine overdose, meaning someone's taken a bottle today, the whole bottle. Okay. Beta adrenergic blockers, if there's been an overdose on those, we can use a drug called glucagon that can that can reverse the effects of a beta adrenergic blocker. Calcium channel blocker toxicity has a lot of potential. These are more treatments than antidotes, but we can give calcium. Since the calcium channel is blocked, we can give more calcium to try and get some through. The other ones are interesting. These are a bit more complicated to explain, but we use IV insulin and IV glucose to try and help this poisoned calcium channel. And there's a lot of evidence that shows that IV insulin in very high quantities can help restore the function of the calcium channel. So it's not really an antidote, it's a treatment for it. Digoxin has an antidote called Digibind, so that's just an antibody that binds to the digoxin and makes it inactive. Heavy metals such as iron, mercury, these are heavy metals that we can use what are called chelating agents. So they're drugs that are just going to bind to the heavy metals such as iron and pull it out of the tissue so that it can not cause its toxicity and help it be excreted. And then of course for an opioid overdose, someone who has taken too many opioids or too high a dose of opioids and they're unconscious, they're not breathing, they have pinpoint pupils, we will give them naloxone. Now remember, the same thing will happen here. If you give someone who's just a bit drowsy but they've been on opioids for years and you fully reverse them with naloxone, you can put them into an acute opioid withdrawal. So severe agitation, potential seizures. So naloxone would be for someone who's either semi-comatose or unconscious and they can't protect their airway, or they have low blood pressure, or they're breathing extremely slowly and they can't maintain oxygenation. We will use naloxone to reverse the opioid effects. Okay, so activated charcoal. We use this a lot in overdoses, in ingested poisonings. As I said before, as long as it hasn't been many hours, because then it's just not active anymore, right? The drug has been absorbed into the bloodstream, so it's too late. But if it's early on, if it's in the first 2 to 4 hours, we'll definitely give activated charcoal, because it absorbs many toxins and drugs that have been ingested, right? So it actually stops the absorption into the bloodstream. And activated charcoal comes as this liquid bottle that we have people drink. It's probably about half a liter, and it just stains everything black. If you give it to a child, there's black face, black hands, black sheets. It's just a mess. And often activated charcoal is in a liquid with sorbitol in it. And sorbitol is kind of like it's a sugar, but it purposely causes some diarrhea because you want the charcoal to work, but you want also to create almost like a laxative effect. So often there's activated charcoal in sorbitol to start the flushing process as well. Okay, we don't give it to anyone who has reduced level of consciousness, reduced gag reflex, because if we're forcing them to take charcoal and then they vomit or aspirate into their lungs, charcoal in your lungs is very harmful. Okay, it'll cause intense inflammation in the lungs, and that will be a real problem. Okay. So normally given as a single dose, but sometimes if we think it's early on, let's give them another dose to absorb as much as possible in the gastrointestinal tract. But remember, Anyone who has reduced level of consciousness cannot be given charcoal. So EDTA. So these two are chelating agents. So whether it's calcium EDTA or dimercaprol, these are chelating agents that are used much less commonly now because we don't have as much lead poisoning around like we used to. You know, lead used to be in paints a lot. It used to be in the fuel that we used. Not anymore. So the acute poisonings are less common. Um, but it can, so this drug, EDTA, can remove lead poisonings from the body, right? It can, so lead gets into the brain, gets into the fat, and lead is by far the most toxic effect of lead is in the brain, especially in children. It causes all kinds of neurological delays, learning abilities, a lot of really harmful effects, right? So this binds the lead and can pull it out of the body and and pull it out of the tissues and get excreted by the kidneys. So I think if you know that EDTA is a chelating agent, I think you're doing fine. Okay, and the other one is dimercaprol. Again, just a chelating agent for heavy metals. We should have a D with metals. Oh, we should have a T with metals, not D. So heavy metals, arsenic, mercury, lead, right? So it can be added to EDTA to pull lead out of the brain, right? So someone who's very lead toxic, I think there was a child about 7 or 8 years ago in the States that unfortunately someone had bought them a toy from China, and the child, a very young child, just played with it all the time, became sicker and sicker and sicker, and they had no idea why this child was so sick, and it ended up being lead poisoning from the paint on the toy, and caused a lot of brain damage, permanent brain damage. So again, forms a non-toxic chemical that can be then excreted by the body. Okay, so I think if you know that these are chelating agents for heavy metals, I think you're doing fine. So nasogastric tubes for poisoning. So remember, nasogastric tubes are put in for many reasons. Uh, we might put a nasogastric tube in, I'm talking about non-poisonings here for a minute, but we might put in a nasogastric tube for someone who has a bowel obstruction, a small bowel obstruction, because we want to decompress their bowel obstruction. And so we'll suck the fluid, the juices, the gastric juices and the intestinal fluids out so they don't get recurrent vomiting and abdominal distension, right? So that's a pretty common procedure. It's a very uncomfortable procedure. In the setting of poisonings, you can put an NG tube down not only to suction some of the fluid back to analyze it. That's done less commonly. I would say the more common reason is to do a gastric lavage, where you put large volumes of fluid down to cleanse the bowel, to flush out whatever's in the bowel. You can also put charcoal down this way too. If they're unable to drink charcoal, we can actually put charcoal through an NG tube. Um, so it's for high volume gastric lavages or to also put charcoal down. So dialysis for poisonings, again, let's just talk about dialysis first. Dialysis is typically used for renal failure. And there's two forms of dialysis. So there's peritoneal dialysis, where you put a volume of fluid into your abdominal cavity, your peritoneal cavity, and it'll sit there for many hours, often overnight, to absorb the toxins that are in the blood and to cleanse the blood, and then you take the fluid out. So that can be actually done at home. Hemodialysis is what you see in the photo here. where someone is on a machine and the blood is being cleansed and filtered through the machine and then being put back into the body because their kidneys are non-functional. This can also be used for poisonings. We can try and take out certain poisonings or certain drugs that are creating the problem with a dialysis machine. Not every drug is dialysable, but many are. So if the typical treatments aren't effective and the patient is getting sicker and sicker and it's a dialysable drug, we will consider hemodialysis to take the poison off out of the bloodstream.